All right, we'll ask people to come back together. Thanks for your continued attention with the challenges of our technology. And now we're going to welcome Dr. Wayne Fuchs to our stage, so to speak. I've known Wayne for a very long time as well. I'm not even sure when, but have really appreciated his dedication to PXE over all these years and his basic both gentleness, compassion, kind of real human effort to keep the humanity and the care in the science and in the clinical care he gives. So thanks very much, Wayne, and thanks for joining us today.
Thank you for that introduction, and I'd like to welcome everybody today. Let me stop that and begin my slideshow. So welcome everybody. I also look forward to the end of this pandemic and welcoming everybody in person in 2 years in Philadelphia. And thanks to Yoni for that great talk. He's always a tough act to follow. And Eric for your comments on the laser surgery and the cosmetics. So today I'd like to speak about how PXE affects the eye. And my slide didn't advance. Let's try this.
Click on the screen.
Okay. So I'd like to talk about first the anatomy of the eye, then the ocular manifestations of pseudoxanthoma, ways to prevent disease complications, ways both the patient and physician may detect complications early, and how we evaluate patients, which includes which diagnostic tools we use. I'll speak about how we treat active disease and try to illustrate some of these principles with cases along the way. And finally, what treatments we may look forward to in the future. Let us begin with the anatomy of the eye. As you can see from this cartoon, the eye may be divided into both the front and the back. The light and images pass through the cornea, which is really like the crystal on your watch. The light then passes through the pupil and through the lens of the eye. And then the image falls into the back part of the eye, where the retina lines the inner surface of the globe. You see the white part of the eye, which we'll refer to, that's the sclera. And then the optic nerve is really the tip of the brain, which brings the image to the brain for interpretation. So the eye is similar to a camera. You have your focusing in the front of the eye. The image gets focused on the retina, which is the film of the camera, which lines the inner surface of the back of the eye. And then the image is brought to the brain, as I said, through the optic nerve. You can see this cartoon also shows that the retina lines the inner surface of the globe, and it goes way past the middle of the eye, or the equator, to nearly the front of the eye. This part of the retina, which lines the inside of the eye, is responsible for the peripheral vision, your side vision. When we speak about the complications of PXE, we're really talking about the very center of the eye, a very small portion of the eye in the back, which is called the macula. If you look at this total picture of the retina, approximately 1 million fibers go into this optic nerve that go to the brain. And this small area, the macula that we're speaking about, represents about 500,000 of those fibers. The macula is responsible for the detailed vision. If you're looking at somebody's face, in order to see their features, you line up their face right on your macula. If you're trying to read a word or a book, it is the macula that is responsible for the fine vision, and 500,000 of those fibers go right into this optic nerve and travel to the brain for interpretation. This is a detailed cartoon of the cellular layers of the macula. We're going to come to this again later, but please note the photoreceptor layer, which is labeled here. This represents the rods and the cones, or what we call the receptors. Underneath that is the retinal pigment epithelium. That's a layer of cells, a sheet of cells, under which is Bruch's membrane, which is a very important membrane, especially in PXE. Bruch's membrane, as you can see, separates the retina from the underlying choroid. The choroid is the vascular layer underneath the retina, and you'll see how that presents a problem in PXE patients when there's a defect in this Bruch's membrane, which protects the retina from this vascular layer. The white part of the eye is the outside of the eye. That's the sclera, which we discussed before. So when we talk about the ocular manifestations of PXE, the most common finding is called peau d'orange. This is, or leopard spots. You can see this disturbance, which is felt to be a calcified and degeneration of Bruch's membrane, which is just beneath the retinal pigment epithelium and in front of the vascular layer or choroid. We will see how this is important later on. It can be described as a widespread area of mottling of the pigment epithelium. These indistinct yellowish lesions resemble the skin of an orange, and that's how it derives its name, peau d'orange. It is the most common retinal finding in PXE, and it affects about 96% of patients studied. It is most apparent in the first 4 decades of life, and it's easily seen in both color and red-free photography. Angioid streaks are bilateral, tapering, irregular lines which radiate from around the optic nerve or papilla. They may be circular, they may be pigmented, as you see here. You can see they're circumferential or circular, and they can be surrounded by pigment atrophy or loss of pigment, and they do represent fractures of Bruch's membrane, which I mentioned before, which contains elastic tissue, which becomes fragile due to calcium deposition in PXE. Angioid streaks may be complicated by choroidal neovascularization, which, as seen on the color photo of the left, one can see faint angioid streaks in this color photo surrounding the optic nerve. But you can see a central scar in this patient. This is a scar because the patient developed these fragile new blood vessels that we refer to as choroidal neovascularization, or CNV. Adjacent to the scar in this patient, you can see an area where there's fluid. It's turbid fluid. It obscures some of the details of the underlying choroid. You see retinal vessels. This would be a vein and a retinal artery, but deep to the retina, you can also see these choroidal vessels, which are somewhat obscured by the fluid. And surrounding the fluid, you see deposition of lipid material from the bloodstream. On the right of the screen is an indocyanine green angiogram, which brings out the angioid streaks. You can see these irregular, tapering, radiating lines, some of which are around the nerve or circumferential or circular. And you can see where the leakage is coming from, this area of choroidal neovascularization, which is lighting up on this angiogram. As you can see, this is the very same patient several years later. This patient was treated previously with laser photocoagulation, we'll discuss later, and had a central scotoma, and vision was 2200. When he developed this new area of neovascularization, he decided not to have additional treatment because of the already central blind spot. However, as you could see, 15 years later, that blind spot has increased in size, and this was before we had some of our current treatment modalities, which might have limited the size of this blind spot had we had them available at the time of presentation. This brings us to strategies to try to prevent vision loss in patients. We recommend a reduction of dairy products and avoidance of smoking, especially in patients who are predisposed to accelerated atherosclerosis. You heard from Yoni about intermittent claudication, and he mentioned vascular disease such as strokes and heart attacks. So it makes sense for patients who are at risk for acceleration of their atherosclerotic disease to avoid these products. A low calcium diet is controversial. It's been recommended to reduce the calcification in some patients, but some studies have shown it to be of very little value.
And when we, just to be clear, because we've been kind of trying to get rid of this as an issue,
Right.
we don't recommend a low calcium diet because it seems that the body will find calcium when it needs to, and if you don't have enough, then we're seeing a lot of osteoporosis in women who have reduced calcium.
So thank you. I was going to hope to defer to the scientists on that issue. Vitamin supplements, we will talk about osteoporosis and osteopenia as well. Vitamin supplements are found to be of value in patients with age-related macular degeneration who have similar pathology but have never been proven to be of value in PXE. Some patients choose to eat a balanced diet that would be vegetables containing antioxidant vitamins, so green and orange vegetables, kale, spinach, sweet potatoes, carrots, things like that. It's a healthful diet for the heart and the brain as well. So Sharon just mentioned the complication of a low calcium diet would be osteopenia, osteoporosis, especially in women later in life. So we do recommend exercise programs for people with PXE, especially to build peak bone mass early in life, in adolescence. So they have a nice buildup of calcium from which the body could derive calcium later on. Sorry. We talk about avoidance of the Valsalva maneuver. The Valsalva maneuver is when you bear down, such as in straining at bowel movements or heavy weightlifting, things that make the face bright red. There have been case reports of bleeding in the eye after such a maneuver, and of course, avoidance of direct trauma to the eye. I have several patients who have had retinal hemorrhages after trauma to their eye. They're at greater risk for a hemorrhage due to these angioid streaks or breaks in Bruch's membrane, even in the absence of the new vessels or neovascularization. So patients should wear sunglasses, as Eric mentioned, to protect them from UV light. And also it's a physical protection so that you don't accidentally walk next to somebody who opens their umbrella into your eye and causes mild trauma that would otherwise be meaningless. And especially during contact or racket sports, patients should wear protective eyewear, as you see in this photo. Early detection of a problem is very important to reduce the risk of vision loss in patients. It starts with identification and education of patients at risk. This includes examination of family members for evidence of this recessively inherited disease and education regarding symptoms for patients to look for. And we will discuss those symptoms, but the patients should routinely review an Amsler grid and report any sudden significant change immediately. They should also go for regular examinations by a trained ophthalmologist looking for signs of choroidal neovascularization. We revisit this cartoon of the deep cellular layers of the retina to explain the distortion experienced when angioid streaks develop new blood vessels or choroidal neovascularization. As I said, the choroidal vessels are separated from the retinal layers by Bruch's membrane, which can become calcified and fragile. If dehiscences or breaks develop, these small ruptures allow the vessels from the choroid to grow under the retina, elevating the retinal tissue, the retinal pigment epithelium, as you see in this cartoon. When the retina is lifted up by these vessels, which tend to leak fluid, the receptors are displaced and the image interpreted by the brain is distorted. So you can imagine if you had an image that fell on 100 receptors before, now that the retina is stretched out, it may fall on 80 receptors and it would be quite distorted to the brain. And so that is a term that we call metamorphopsia. Patients are provided with an Amsler grid by their physician, or you can easily download a grid from the computer. If there's a decrease in one's acuity, or the grid develops areas of distortion or dark or blind spots, we ask patients to report these symptoms immediately to their physician. Here you can see an artist's view of metamorphopsia, which was published in JAMA in 1983. Dr. Billings was a physician and trained artist, and he experienced bilateral macular degeneration that was more severe in his right eye. And to demonstrate how his vision was affected, he painted a series of oil paintings using first the vision of both eyes and then the vision in the more severely affected right eye alone. Please note the distortion of the regular contours and general loss of fine detail and overall darkening of colors. This is the picture he painted with both eyes open, and on the right, the distorted vision in his affected right eye. This brings us to methods used to evaluate a patient in the office. Most important is, of course, the visual acuity. That's the bottom line. That's what we're trying to say for the patient. The doctor performs a dilated exam looking for signs of choroidal new vessels. These include bleeding, lipid deposition, and fluid. We perform several diagnostic tests to help us, which include fundus photography. We can use color, red-free, or autofluorescent photography. We have angiography at our disposal, both fluorescein and indocyanine green angiography. ICG angiography does offer certain advantages in evaluating patients with PXE. It can better visualize angioid streaks as well as peau d'orange. Due to the infrared wavelength of ICG angiography, we can also visualize choroidal neovascularization through the pigment epithelium, and especially if there's a pigment epithelial detachment. It can also better delineate areas of neovascularization, and it could image through a thin layer of blood due to the wavelength. Optical coherence tomography is an indispensable tool, and we have used Stratus, Cirrus high definition, and most recently OCTA or OCT angiography. OCT, of course, stands for Optical Coherence Tomography. Tomography being slices of the retina, so we can look at a side view of the retina. Here you see a color photograph which demonstrates the angioid streaks, which are tapering and irregular and surrounding the optic nerve. We call them peripapillary again, and temporal to, or on the outside of the macula, the peau d'orange, which we described before, which is again better seen in the red-free photograph, as are these tapering irregular breaks in Bruch's membrane or angioid streaks, which derive their name because of their similarity in appearance to the retinal vessels, which you see here, a retinal vein, a retinal artery, and an adjacent angioid streak. Autofluorescence photography easily demonstrates the peripapillary angioid streaks. Fluorescein angiography shows the streaks, and in this particular case, they appear very wide because they're surrounded by pigment atrophy. So the fluorescein dye shines through the absence of pigment, and you can see the choroidal vessels crisscrossing these areas of pigment atrophy. And indocyanine green angiography again shows the peau d'orange, the speckled pattern, the hyperfluorescent peripapillary angioid streaks, which can be both linear and circumferential. And this is one example of a device that we use. This happens to be a Zeiss Cirrus 6000 OCT machine, OCT abbreviated for Optical Coherence Tomography. It's invaluable for evaluating patients for evidence of active disease. This machine takes about 100,000 images per second and compiles a cross-sectional and, if you want, three-dimensional image of the retina. We can view different levels of the retinal vasculature by manipulating the image. This is an example of a 52-year-old with angioid streaks. He also has a reticular pigmentary change and has pigment clumps on both sides of an angioid streak, which we term an owl's eye lesion or wing sign. You can see the pigment loss or pigment atrophy surrounding the streak, which I just mentioned. The OCT image, the high definition vertical images, go right through the angioid streak in this patient and the pigment clump, and you see the image just below. So there are 10 layers of retina imaged here. You see the center of the macula. There is a nice concave curve because some of the layers of the retina thin out in the macula, which allows us to see detail better. And the very, very center of the macula we call the fovea. You can see in this patient there is some fibrous tissue just underneath the fovea. Adjacent, there is some subretinal fluid. You can see where this image goes through a pigment. The light hits the pigment, which then shadows. And you can also see a break in the retinal pigment epithelium and Bruch's membrane complex. We sometimes have difficulty separating out the layers of the retina, so we do refer to this as the ellipsoid zone. And you can see a speckled pattern in Bruch's membrane in this patient. Under the retina, again, this is the choroid, and you see the choroidal vessels, much larger vessels than the retinal vessels, cut in cross section. You see some are circular, some are more oval shaped. Here's a patient who, this is the Cirrus OCT, which gives us a lot of information. The horizontal cut is seen here, and the vertical cut just below. The image is it's a black and white machine, but we add color for ease of visibility for areas of retinal thickening. So the red area is alerting the doctor to the fact that the retina is thicker than usual. The wider area shows that it's at least 500 microns thick, which is half of a millimeter, which is about twice as thick as normal. The reason it's thick is because underneath the fovea, which is the center of the macula, you have a fluid collection in this patient. The data is quantitative. It's telling us that the thickness is 436 microns, and that's very valuable for comparing this to future images after treatment to see if the treatment is effective. Which brings us to treatment. There's a little history lesson here. Laser photocoagulation was the treatment of choice for these abnormal new vessels that were not in the center of the eye. This was prior to the advent of our anti-VEGF injections, which we will talk about in a moment. We could only use thermal laser photocoagulation when the vessels were outside the center of the retina or outside the center of the macula, which was true in between 5 and 10% of cases. So close to 95% of patients could not have laser treatment because the neovascularization was in the center of the retina, and we would create a scar with the laser, which was just what we were trying to prevent. So photodynamic therapy or cold laser became a treatment available for vessels that were located under the center of the retina. This did not cause a scar, but it was effective only in slowing the vision loss. It didn't really stabilize patients or improve the sight in patients. Because we had no effective treatment for vessels under the retina, we tried multiple surgical attempts to restore vision by retinal translocation, which meant that we detached the retina, rotated the retina, and reattached it. It was a multiple-hour surgery and did not really improve the vision in large studies, as well as submacular surgery. We actually have tiny tools when we could go inside the eye and remove the scar from underneath the macula. But unfortunately, when removing the scar, we also remove some of the rods and cones, and the vision was shown not to benefit from such a procedure in prospective studies. Fortunately, anti-VEGF injections came on the horizon. Macugen was the first anti-VEGF injection that was approved by the FDA in 2000. Unfortunately, like photodynamic therapy, it didn't actually improve the vision in patients, but slowed the rate of vision loss. Macugen was also called pegaftinib, and it really lost favor when some of the other agents came on the market. It basically, the problem with Macugen was that it only blocked one of the isoforms of the 5 VEGF proteins. VEGF stands for vascular endothelial growth factor. It's basically a protein that the eye produces that causes proliferation and leakage of blood vessels. So we block this protein with an antibody, which we inject in the eye. And a very important anti-VEGF agent that was approved in 2006 was called Avastin or bevacizumab, and that was approved for cancer chemotherapy. We will discuss that later. That is made by Genentech, and approximately 6 months later, Genentech had approved by the FDA Lucentis or ranibizumab. That was June 30th, 2006, and that was a breakthrough treatment that blocked all 5 isoforms of vascular endothelial growth factor, and that was the first medication that actually improved the vision in between 30 and 40% of patients and stabilized 90% of eyes. Eylea, or aflibercept, was approved approximately 9 or 10 years ago by the FDA. That's made by Regeneron, a company that many have heard of recently, who are producing antibodies against our pandemic virus, COVID-19, not approved yet by the FDA. Beovu came on the market 1 year ago. That is made by Novartis, and that promised to actually last longer than the other anti-VEGF injections, and it seemed to work that way, but has had some problems, which we can discuss in the Q&A later. But the basic problem was that it causes more inflammation in eyes than the other anti-VEGF injections, and has actually caused not just mild inflammation that could be treated with eye drops, but inflammation of the blood vessels or vasculitis and vascular occlusion. So it was approved in October of last year, but reports surfaced in February of 2020 about vascular occlusive disease. And so we now warn patients about possible vision loss from an irreversible vascular occlusion, even though it's rare. And those case reports were 1 patient in 70,000 initially. But again, we have other agents that we can use. And so thank God we have an armamentarium to use when people have leaking blood vessels. Of course, the problem with VEGF, I mentioned, it causes proliferation of vessels and leakage, but ultimately it can be bleeding, and bleeding can leave a patient with a central scar. And so we really do try to stabilize these blood vessels. Some physicians have used steroid injections in addition to these anti-VEGF injections. And of course, we've done studies for the systemic disease using, as Sharon Terry mentioned, oral phosphate binders and magnesium supplements, which we can discuss with limited results. Those agents have not shown statistical significance in the reduction of systemic mineralization, although there was a positive trend in the magnesium trial, which studied 40 patients. Of course, for those patients whom we cannot help medically, we always offer visual rehabilitation with the use of low vision aids. Dr. Lorraine Markey, may she rest in peace, was really the founder of low vision aids. She started the National Association for Visually Handicapped, and she was a consultant to PXE International. She was the first person to introduce low vision aids and was able to get Reader's Digest to print the first large print material for patients with low vision. So this brings us to, this is an example of a patient who actually did well with laser treatment. The reason this patient did well is the area of neovascularization was just above or superior and temporal to the macula. So the area of leakage and bleeding was treated with argon green photocoagulation. You can see the thermal scar here, which was several millimeters from the fovea and was a successful treatment, one of the 5% that was able to be treated with laser. Here's an example of one of the first patients that I was involved with in 1984, who had presented with these irregular angioid streaks with pigment atrophy, which imparted a feathery appearance to the streaks and decreased vision in the right eye because of a neovascular complex. You can see the pigmented or slate gray lesion adjacent to the fovea in the macula of this 33-year-old diplomat. It was surrounded by hemorrhage and treated with initially a krypton red laser because of the proximity to the center of the macula. The macula has luteal pigment, and the red wavelength of the laser did less damage than the green wavelength. Unfortunately, he recurred and required green laser treatment. You can see the fluorescein angiogram on the right, which shows the neovascularization lighting up like a light bulb. He eventually stabilized 6 months later and maintained vision of approximately 20/60, but as many of our patients experienced, a second area of leakage developed, and you could see some turbid fluid. We call this a neurosensory detachment surrounding a second area of neovascularization in this patient. He was treated for this lesion with photocoagulation long before anti-VEGF agents. Another patient that was successfully treated with laser. This 48-year-old artist participated in the phosphate binder trial. 1 year after the trial was completed, she noted decreased vision in the right eye. Note the deep retinal hemorrhage near the fovea and the subretinal fluid. I have to go back one. On the stratus OCT, this is an old version of optical coherence tomography. The center of the fovea is here with the concave contour, and adjacent to it was subretinal fluid. And you can see in the red-free photograph, the fluid outline and the hemorrhage in the black and white picture is seen more easily. The indocyanine angiogram shows the tapering angioid streaks. There's a little late leakage associated with the neovascular complex. You can see the Peau d'orange very easily. And this patient had a choroidal nevus, which is also seen very well on the indocyanine angiogram. The reason the date was important, the patient presented 1 year after the study ended, but it was several weeks after Lucentis had been approved by the FDA, and she received 3 Lucentis injections with vision returning to 20/25 and resolution of the hemorrhage. I last saw this patient 5 years ago, and she had many more treatments in the interim and was still maintaining 20/25 vision. Another of my patients was a 44-year-old who noted metamorphopsia or distortion in the vision on the Amsler grid in her left eye. She had been followed since age 21, so she picked up this subjective complaint. Vision remained 20/30. Again, in the color photograph, you can see a slate gray lesion, which is better seen on the angiogram. It lights up on the fluorescein study. Her OCT showed, as remember, the color code for thickness. So there's a red discoloration just above and to the left of the fovea. You can see thickening on the horizontal cut and fluid underneath the center of the fovea. The central retinal thickness was 320 microns, a little thicker than normal. 1 month after an anti-VEGF injection, the thickening is gone, the fluid is gone, and the center thickness returned to a normal 258 microns, and her vision returned to normal. The importance of the AMSLA grid and the regular review. My last case is a 39-year-old web designer who was noted to have a hemorrhage just on the nose side or nasal to the fovea on her 12-month visit during the magnesium trial. OCT revealed the central scar with fluid, both nasal and temporal, as well as superior. This is the vertical cut, and the fluid is up here on this side and that side. You see a central scar in this patient, which she developed after trauma at age 16. She was hit in the eye during a judo competition, which resulted in a retinal hemorrhage. She was hospitalized for that hemorrhage, and they made the diagnosis of PXE by neck biopsy during that hospitalization. Again, a reminder to wear protective eyewear. She has, over the course of several years, developed additional hemorrhages. This is just below the fovea and superotemporal to the fovea. She has these circumferential breaks, which may be related to her trauma, but she does have angioid streaks. She has other features of PXE, which include these salmon spots, which are variably pigmented, flat lesions with a tail of depigmentation posteriorly, which give them a comet-like appearance. She also has a few calcified drusen. We look for some of these features when trying to make the diagnosis of PXE when examining family members and try to educate patients who might be at risk for vision loss. Here is her OCTA, reveals the central scar. We look at different layers of the retina, and you can see in the deeper layer a choroidal neovascular membrane in the right eye. In the horizontal view, you can see the central scar, which is vascularized. You can see the color coding for vessels, which are either red or green. And so we were able to confirm the neovascularization in this patient. 3.5 years ago, she presented with decreased vision in her better eye, her left eye, and you can see several deep retinal hemorrhages just left or nasal to the fovea. The OCT shows thickening in that region, as well as subretinal fluid, cystic change overlying the neovascularization, and fluid in the macula. 1 month after treatment, the fluid dried up and vision improved. Approximately 12 months ago, she presented with decreased vision in the left eye. Neovascularization was now adjacent to the fovea, perifoveal or juxtafoveal, and she was treated with additional anti-VEGF injections. So 6.5 years after initial presentation, she's now had 28 injections in the right eye, maintaining 20/40 vision, and 16 injections in the left, seeing better than 20/30, and I just saw her 2 days ago. This brings us to future approaches. The future is bright. We have these wonderful agents now, but we are looking into agents that last even longer, as well as improved delivery systems. Penetrating peptides may help eye drops penetrate and get to the back of the eye and help us to avoid injections, which are, of course, dreaded by patients, and there is a small risk with each injection of infection or retinal hole and detachment, and so we would like to avoid injections, which brings us to another future advance, or where we can implant a plastic device in the eye, and that can be refilled instead of an injection in the eye. We could refill the device every 6 months. As I mentioned, eye drops have been studied. Unfortunately, they're not as effective as the intravitreal injections where we administer the medication. And the FDA has a problem with approving medications that are not as effective as ones already approved. It's called the non-inferiority rule, but the risk profile would be much less if we had an eye drop that would be nearly as effective, and I'm sure they would take that into consideration. You may have heard a little bit from Yoni's talk about pyrophosphate, inorganic pyrophosphate, which might be taken orally. This is deficient in PXE patients. We mentioned the magnesium supplements that may be effective. We need larger studies to prove that this is effective. And the TNAP inhibitors or inhibiting some of the enzymes. Stem cell therapy is in the future, as well as retinal pigment epithelial transplantation. And ultimately, we need methods of preventing this disease in the first place. Gene therapy is in the future. We already actually have one gene therapy approved for the eye. Luxturna was approved in December of 2017. It's the first FDA-approved drug for gene therapy, and that's for patients with an inherited retinal dystrophy, which can cause Leber's congenital amaurosis or blindness at a very young age. So in summary, I've described some of the clinical manifestations in pseudoxanthoma in the eye, some of the diagnostic tools that we use to identify and evaluate patients at risk for disease, including photography, angiography, and OCT. The treatment options, which include laser, photodynamic therapy, and anti-VEGF injections, as well as future approaches, and illustrated some of this with case presentations. Anti-VEGF injections do stabilize 90% of eyes with choroidal neovascularization. Patients should be treated early and have careful follow-up. Patients should be educated to look for symptoms, including decreased vision, blind spots or scotoma, and metamorphopsia or distortion. Doctors look for signs such as blood, lipid, and fluid. And although we have wonderful treatments, we are always looking for better modalities for the prevention and treatment of ocular complications of PXE. Thank you for your attention, and I'm happy to take any questions.
Great, thanks so much, Wayne. As usual, very informative. So we have a couple questions. Matthew, do you want to name the one that came in Spanish that you translated, and then I'll call on a couple other folks here too.
Sure. So the first question was related to, well, first of all, thank you for presenting. Sorry, shouldn't skip that. Appreciate you being here. But the first question was related to the nanotechnology drops, and the question was, and again, this is translated, but it's essentially, are they recommended to supplant the Lucentis treatment, and how reliable can these drops be?
Well, there's certainly nothing approved at this time, and we look forward to nanotechnology. So I don't know, I don't think that it would be a welcome substitute. It would immediately replace intravitreal injections if they were able to penetrate the cornea and get to the back of the eye.
Great, thanks very much. Catherine, you can unmute.
Yeah, is that, can you hear me?
Yes.
Okay, so my question is, I've had persistent subretinal serous fluid that won't reabsorb. I've had injections for 5 years, and I've had PDT just this past summer because I am now down to counting fingers in that eye. That was my only good eye. And now he's talking about like maybe just stopping injections altogether, or using eplerenone, because I guess there's two retinal specialists arguing if it's CSR versus PXE problem.
Okay, so sometimes we do see persistent, so the better eye has subretinal fluid and the vision in the better eye has dropped to counting fingers?
Yes, like in the past, I've lost 3 lines on the eye chart just in the past 3 months.
So it won't encourage you that I will mention that sometimes, but maybe it'll reassure some other patients, sometimes there's persistent subretinal fluid. And we have found that patients with a little bit of subretinal fluid that remains stable sometimes can be watched, or we still treat them, but we know that all of that fluid doesn't go away all of the time. And some patients do see very well with a little bit of subretinal fluid. It seems to affect the vision less than cystic fluid. So we've come to tolerate a little bit of fluid. Originally, we had 0 toleration for any fluid, but sometimes we can't get rid of the fluid, and we've tried adding steroids, adding PDT and other modalities, and it's sometimes very well tolerated. In your case, you've had a decline in vision, unfortunately. You mentioned that there's some confusion with this other condition. We didn't talk about that at all, central serous choroidopathy. That's a much more benign condition usually. And that's something that we see in patients who we talk about type A personalities, stress in general. It can be seen in pregnant women. It can be seen in people with a lot of stress, and it can be seen in patients who have taken steroids. We see it in recipients of organ transplants sometimes, but it turns out it's that they were on steroids usually to prevent rejection. So, but quickly, central serous is something that we usually watch because it gets better by itself over 90% of the time. We usually don't treat it. And we do treat it sometimes if a patient's had it persisting for more than 6 months with vision loss.
I've had it for 7 years.
Yeah, you've had it for several years, so that's possibly why the vision has declined. But do you have central serous before you had PXE? Or
no, I lost my first eye to PXE at 19.
Okay.
But my retinal specialist felt that the good eye, it was CSR in the beginning, and I didn't have a bleed for 2 years.
Okay, so, and then you had a bleed.
And then I had a bleed, yeah.
Okay, so central serous, so even central serous, which we used to call benign central serous choroidopathy, is not always so benign. And in some reports, it can be complicated by fragile new vessels or choroidal neovascularization in up to 30% of eyes. And so we do look for signs like blood or lipid, and some of those patients do need to be treated because they do have choroidal neovascularization, even people that started with central serous, but usually it's benign. So getting back to central serous and the drug they're recommending for you, we have no known scientific treatment for central serous. We've used the cold laser or photodynamic therapy. You mentioned you had that. And there are pharmacologic agents to block steroids, agents that alpha adrenergic blockers that you mentioned, which are being used experimentally to try to dry up the fluid. So it's very little to lose, but it is experimental, not proven in large multi-center prospective studies, which is what we like to base our scientific recommendations on. But I think it's a reasonable thing to try.
Okay, thank you.
Thanks, Wayne. So we have about 15 questions in the chat, and we have 2 people teed up. So I'm going to try to get these all in. Let's see if we can have the questions be short and.
Well, I can also go into the lunch break if so we can try to answer all the questions if necessary to go late.
Great.
But we'll let people have lunch who need lunch.
Right. Thanks very much. Cheryl, you're next. Can you unmute?
Oh,
We're going to have Cheryl speak right now, and we're taking people in order. So go ahead, Cheryl.
Can y'all hear me?
Yes.
Thank you. I have like 2 questions, really. I have been looking into stem cell therapy. I have gotten approved for one here and one in Mexico, but they're very pricey. I'm really looking at the one in Mexico. They do stem cells using umbilical cord cells from the United States. They don't use your own cells. But my question, I'm getting approved because my doctor had to diagnose me as wet macular degeneration for my insurance to pay, so he couldn't put PXE. So they know I have PXE, but I'm really going for wet macular degeneration. I just want to know, has anybody with PXE that you know has tried stem cell therapy?
So I don't know personally. I would just be cautious about stem cell therapy if it's sort of in a clinic. There were a couple of cases that were reported even in the New York Times. I'm smiling because of the fake news thing, but the New York Times, there were 4 cases in Florida where people were treated in a clinic and they lost vision. So there are a lot of these rogue clinics that are doing stem cells. So if you mentioned that you were approved in 2 for here, you said here, I don't know where you are, but I know
It was in
London,
Florida here.
in
So.
Florida, yeah. So
Yeah.
that's be careful about. So if you were in London and you said I was approved here and you were talking about the Moorfields Eye Clinic, that would be another story. I know it would be done under strict conditions. And so I am afraid of people traveling to places like Haiti, and I hate Cuba or Russia or Mexico, and not getting the same kind of treatment that you would get in a study at a facility like Moorfields or Bascom Palmer Eye Institute or the Wilmer Eye Institute or the Shea Eye Institute, where they do top-notch, or Jefferson Medical Center.
All right. Thank you very much.
Wait, one more question?
So Cheryl, we have about 20 questions teed up,
Okay, that's okay.
and you can put it in the chat and maybe we'll get to it. Sorry.
Okay, that's okay.
So let's keep the questions short, please. Dina?
Hi. Hi, Dr. Fuchs. Good to see you. Thank you for a great presentation. I'm just wondering, there was an article or some articles about a year ago about that there might be some risk with the tests, like the OTC, and also with the, when the doctor is shining the light in your eyes. Do you know anything about that? Do you think there are any risks involved?
I don't think there's any risk with the OCT. It takes about 2 seconds. I know I mentioned it's taking 100,000 pictures, but it's not shining a bright light. And photography is non-invasive. If you're injecting dye, like fluorescein, there can be an allergic reaction. Indocyanine dye, people who have iodine allergies, because the dye is prepared in a certain way, we avoid using ICG dye. You could have an allergic reaction. It could be 1 in 1,000, but it still can lead to an anaphylactic reaction, so we are careful about that. And as far as looking into bright lights, obviously, there are studies that show we can do damage to the retina. You know, we've done it. We can burn the retina with bright lights with laser. Laser is basically a coherent light, but the amount of light we use in our photographs are not felt to be damaging. In fact, there's a new treatment being studied for people with dry macular degeneration where they look at a red light for 3 minutes a day, and it's so far showing some promise. It's being studied, not yet approved. So, but I would block all the ultraviolet light. Eric Goldstein was talking about blocking that with the shields in your car windows, and ultraviolet light's of course invisible and it's not useful light in terms of vision, and it's certainly may be damaging. The short wavelength lights, blue light and ultraviolet lights, are the most damaging, so we do recommend blocking those. But I don't think the diagnostic instruments we're using are damaging.
Thank you.
Great, thanks very much. All right, we're going to go to questions in the chat. So Wayne, is it recommended to take anti-VEGF shots on a schedule for preventive measures? We get this question all the time. Or wait until a new symptom appears? And does one become resistant to anti-VEGF shots?
That's really 3 questions. So first of all, prophylactically, never. That is, if you do not have wet macular lesion, if you're not leaking or bleeding, if there's no neovascularization, we do not recommend injections in the eye. They do have some risk. And if there is already established neovascularization, it becomes a trickier question. How frequently are shots given, at what interval? So there are several different strategies. So different doctors have employed different strategies, and usually you come up with a strategy with the patient depending upon how active their disease is. But so the shots last, let's say, at least a month. And sometimes the original studies were done, it's a long answer to a short question, but the original studies usually used 3 injections, 3 months in a row, and then we studied either withholding or as needed versus monthly injections. A large trial was done in, and these trials I'm mentioning, of course, were for age-related macular degeneration, which has similar pathology. But there was a large study with thousands of patients called the CAT trial, the Complications of Age-Related Macular Degeneration Treatment Trials. That's why we call it CAT for short. And it just showed that only used 1 injection. If the patient was dry after 1 month, they did not have a second or third injection, and they were compared to the monthly injections. And so some patients did just as well treated on an as needed or PRN basis. The problem with deciding how to treat patients is that in the real world, we're not seeing people every month. They're not getting monthly injections. They come is certainly less frequent than the patients in the study. So over the years, patients don't do as well as the ones that we publish in the studies. But if someone is vigilant about their appointments, we can stabilize the vision 90% of the time. So what are the strategies? The main strategies are to treat every month, or if you're using one of the longer lasting drugs, you can treat 3 months in a row and every 2 months, which most patients don't like and most doctors don't like, because sometimes you don't need that many injections and you're subjecting yourself to a risk every time you have an injection. So most doctors try to withhold injections if the patient looks great, dry, and then we follow them carefully. Some doctors, if the patient looks dry, will say, look, you look great today, let's give you a shot today, and next time you'll come back in 5 weeks. Great, you look great in 5 weeks, we'll give you a shot today, next time come back in 6 weeks. And that's a strategy we call treat and extend, and that's a very popular strategy. And usually when doctors do that, they don't extend past 3 months. But again, someone may never need a shot the rest of their life, so we try to withhold until there's a recurrence of leakage. And then that brings us to another strategy. So there's treating every month or every other month, then there's treat and extend, and then there's treat on an as-needed basis. That is, if you have evidence of leakage, if you have evidence of new bleeding, if you have new symptoms, we set the bar very low for treatment, but we treat on an as-needed basis. That is, if you are looking dry and you have no visual complaint, we send you home and say, come back in a month, come back in 2 months. If you haven't had a shot in 2 years, we might even say, come back in 3 months. But those are the 3 strategies. They're all good, they're all used, and the patient has some responsibility to monitor their eye and report any change immediately if we've withheld.
And how about, I'm skipping around a little, but just to stay in the same category, how do you choose between Lucentis or Avastin or Eylea or the new drug?
Okay, so someone just a moment ago mentioned insurance issues, so that plays a role, and mentioned being labeled age-related macular degeneration, and so we do that sometimes. I must say that it's harder if someone's 30 years old to tell the insurance company that they have age-related macular degeneration, but if someone is more senior, in their 50s or 60s, we can say, well, we don't really know if this is from the angioid streak or from age-related change, and we can feel comfortable that we're not committing insurance fraud, and we can use a wet macular degeneration code. And so then the other more expensive agents are available for us. So basically, Avastin is as I mentioned earlier, and I knew we would come back to it, approved for cancer chemotherapy. It's not approved for macular degeneration, and it's not approved for PXE, and it's not approved for injecting in the eye. But it is an anti-VEGF agent. And when it was first approved in 2006, January, I believe, we did not have any agent to inject in the eye. And this doctor in Florida, Philip Rosenfeld, was the first to report how it worked in the eye. He was brave enough. He was doing some of the studies. He's a PhD, brilliant guy, and realized that it's an anti-VEGF molecule very similar to ranibizumab or Lucentis that was being studied by Genentech, same company. And it was just, Avastin's a larger molecule, and the concern was that it wouldn't penetrate the retina. But in those 6 months before we had Lucentis, it was injected in the eye with permission, IRB approval, and all of that, and it worked. So we now had a medicine to inject in the eye, and there was nothing available. Then Lucentis was approved, and of course, instead of it was approved by the FDA in June 30th, 2006, and cost close to $2,000 a dose. Avastin, we'll go back to, is not a cheap drug. It's $5,000 a dose, but it comes in a vial, and it's used intravenously for cancer chemotherapy. So if you take that sterile vial and break it open, you can make 50 doses for the eye. So we send that vial to a compounding pharmacy, and they could make 50 doses for us to inject in the eye, so it ends up being very inexpensive. So Avastin costs about $50 a dose compared to $1,930 a dose, which Lucentis costs, which is the same company, anti-VEGF drug. Avastin's used in this country more than any other anti-VEGF drug for treating the eye we're talking about. So it's not something that doesn't have a track record, and the risk profile is the same, and it works the same in most of our studies. There are some mild differences now in the newer drug, Eylea, that was approved by Regeneron. It was studied in a head-to-head trial comparing to Lucentis. And Eylea was shown in a study, if you gave 3 injections of Lucentis, and then every month injected a patient with Lucentis, and then compared that to 3 injections of Eylea, and then Eylea given every other month, that they had the same result. So Regeneron claims that Eylea lasts twice as long. Well, that's a little bit of an exaggeration because most of us know that we can use Lucentis in patients and it can last 2 months sometimes and even 3 months. But Genentech has not challenged that study and done their own study where they did quite the opposite. And I think Eylea probably does last a little longer, or they would do that study. And then I mentioned Beovu, brolucizumab, I get confused with the name sometimes. Brolucizumab, which is the newest one approved a year ago, which also claims it's an even smaller antibody fragment, can last even longer, but it does have the problem with inflammation. So we can offer any of these agents to our patients if they have no insurance or their insurance doesn't cover one of the approved anti-VEGF drugs. We certainly use Avastin, not fearing that it's inferior in quality, but we do lose the possibility that it may not last as long, but it works.
Great, thanks. Retinal atrophy, talk about that, please.
Well, retinal atrophy. So there's 2 things to talk about with that. Patients with PXE can have atrophy of the pigment epithelium. In fact, there was a report in the literature by Stephen Sang of Columbia of a patient that actually I know who had loss of vision from progressive atrophy. And we see that. And there is no treatment for that. That's similar to dry macular degeneration, where we do not have a treatment. Of course, lots of research is being done on that right now. The other part of the question is, do these anti-VEGF agents cause pigment atrophy? And so there is some that think that it might. I am waiting for results of long-term studies to see if it does or does not, but the consensus is that if someone has active new vessels, that the risk of no treatment outweighs any consideration about pigment atrophy, which is certainly mild. But if there is pigment atrophy, let's go back to that. So the risk of active neovascularization is not just the long-term fluid, but the risk of a bleed. If someone has a hemorrhage in the center of the eye, even though the blood eventually goes away, it leaves damage. So there's usually some decreased vision or some kind of central scar, hopefully small one. So we're always trying to prevent a hemorrhage. And of course, we want to dry up whatever fluid's there. Now, sometimes when we dry up fluid, or even if there's fluid in like that benign condition, central serous we mentioned before, when the fluid dries up, it often leaves some pigment atrophy and pigment clumping. So now that we have agents that can dry up the fluid, when the fluid goes away, sometimes there's some pigment loss. That doesn't mean that the medication caused the atrophy. It's the fact that there was fluid there, which dried up, that can lead to atrophy. But even if the medicine did cause atrophy, the risk of withholding the medicine is far greater than the risk of the medicine. So we advocate giving a shot in the presence of active disease.
Great. Thank you so much, Wayne. We're going to go now to a 45-minute break. Very important for the hygiene of one's physiology, et cetera, to get away from the screen. So we're gonna end here, but we want to thank you very much for joining us and giving us.
Thank you for inviting me. Thank you.
Thanks. Okay, folks, we are going to the lunch break or dinner break or breakfast break, wherever you are in the world. I have arranged rooms for you to go into for your break so you can eat with others from your geographic region, as well as I can match you up. So if you put your state or country after your name, then I have put you into a room that at least similar areas are together. You don't have to unmute and take your video off and eat with others if you don't want to. But it's an opportunity, just like we were at a meeting, we might have tables with little signs on them for you to join others. And so we're gonna go into those rooms now. You'll see a little sign pop up on your screen that invites you to a room, and you can accept the invitation or not, as I said. And any questions that were not answered or are appearing now, we will collect and we will get answers back to you. All right, so we'll see you all at the top of whatever hour and whatever time zone you're in. Thanks, everybody, and especially thanks to our speakers this afternoon.